our three panellists for coming on board. It's a short session. We only have half an hour, so it's a series of quick fire questions and answers, which I think everyone will get a lot out of. The importance of working collaboratively with peak and professional bodies across the whole healthcare sector and different advocacy areas, I think is really something that perhaps we don't do enough of, and we need to think about the value we can add by working together more effectively. I'd like to welcome Paul Power, CEO of the Refugee Council of Australia, Ken Griffin, CEO of Primary Healthcare Nurses Association, and Simon Ruth, the CEO of Thorne, Harbour Health. So we'll get into our first question. If I could start with Paul, we're looking for you to describe your work and how working collaboratively has advantages. And if it does, what are the disadvantages? And when do things not work? Thank you, Paul. So we've got about 5 minutes. We'll move on to Simon and then to Ken.
Yeah, thanks, Claire. So the Refugee Council of Australia has been around since 1981, and we're the national umbrella body or peak body for organisations working with refugees and people seeking asylum. And really the need for our organisation is based on the fact that most organisations that are part of our membership are working at the local and state level, and yet the policy framework which influences their work is set at the national level, and there are also a whole lot of international trends which impact on the work of local organisations in Australia. So our role is to be, the voice of our network at the national and international level. As it's useful for people to know that our organisation receives no federal government funding. An immigration minister by the name of Scott Morrison put paid to that in 2014. Not that we actually ever received large sums of federal government funding. It was only ever about a quarter or a third of our income. But so we are very much reliant on having a strong supporter base, donor base, and membership fees to survive. And so, and we do all the things that a peak body does. We spend a lot of time listening, because you can only be an effective voice if you actually understand the needs of the people and organisations you're trying to represent. And our role is to listen and to help translate the ideas and concerns into policy proposal submissions and advocacy to the national and international level. And we're also, I think peak bodies play an important role in being a source of factual information. So the statistics that the Refugee Council produces are very well regarded by our network, by researchers, and also by the media. In terms of challenges, and possibilities of working together, I mean, one of the challenges that our sector faces is a view amongst politicians that there's a lot of division amongst people advocating for refugees. And that's also, I suppose, because refugee policy is so politically contested. There are a lot of organisations and movements that are involved in commenting publicly. The public voices you hear on refugee policy, cover everything from very cautious organisations that are quite heavily involved in programs, such as Australian Red Cross. And we know Red Cross has all sorts of constraints on the way in which it traditionally advocates, through to, individual advocates and, volunteer refugee action collectives and the like, that are associated with the far left of Australian politics, and everyone in between. And what we've learned over the years is that no umbrella body can, control or encourage, a common perspective on how to advocate, or, what's the most appropriate way of promoting discussion in the public arena. But one thing that we've been able to do is actually get a common perspective on what the problems are and what the issues are. And we started this in 2017, with a series of discussions of people who'd never spoken to each other before, and also had all sorts of views about others, who were participating in the discussion. Even though, and what we discovered through a year of dialogue is that, even the most radical activist groups and the most conservative government-funded bodies actually had a very similar perspective on what the problems are and what the policies policy alternatives should be. So for the 2019 election, and we've actually just reissued it for the 2022 election, we've produced a platform for change on refugee policy, which outlines the key issues, and I'll put that in the chat in a minute so people can see it. But it shows that even though, you know, some people will feel that the best approach for them and their organisation is standing outside government offices shouting through megaphones, and others will believe it will be insider advocacy in Parliament House, we actually have a common understanding of what the issues and concerns are. And I think that's an important role that a peak body can play. Also, you know, our organisation has played a significant role, I would think. I mean, obviously I'm biased, but I think people who are looking outside would agree that Refugee Council of Australia has played an important role in supporting a much stronger voice of lived experience on refugee policy in Australia. So since 2007, we've been supporting refugee community representatives to participate at key international meetings, particularly the United Nations in Geneva on refugee policy. And when we started that, ourselves and the University of New South Wales were the only NGOs in the world that are actually taking refugee representatives to these meetings, because this was regarded as the role of, you know, of professional NGO reps rather than of people with lived experience. But over the years, we've seen a real change in nationally and internationally in the way that that's happened, you know, and I think, you know, for a small organisation, played an important role, you know. And so in 2012, we were co-chairing the international dialogue with UNHCR and governments on refugee resettlement. We had the opportunity to push for refugee representation at those important annual discussions, and now there's actually a refugee steering group, which actually is also part of the co-chairing arrangement. We were involved in supporting or co-sponsoring a global summit of refugees in Geneva in 2018 and an Asia Pacific summit of refugees, which was held virtually across Asia in 2018, which have led to global and Asia Pacific networks of refugees being formed. And we're also involved in supporting the development of a national refugee-led advisory and advocacy group. So, so I think, you know, obviously that connects very well with your organisations today. You know, the people with direct lived experience need a much, will need to be much more a part of the discussion than they traditionally have been. And it just makes sense, you know, in terms of, you know, our organisation has also changed in terms of our board and staffing. You know, it is a much more of a mixture of people with lived experience, and those myself who are Australian born and don't have that lived experience, but have different forms of expertise to bring to the discussion. So I think, yeah, you know, and there are still many challenges, as you could imagine, in such a highly contested area of policy. But I think, you know, there are two areas where there has been significant progress in the way in which people who are concerned about the same issues are working together.
Yeah, that's fantastic. And it really encapsulates, I guess, how that translates across any group, be it patients, anyone who has a shared experience or a shared cause, just that importance of being able to communicate. Simon, do you have anything you could add to that comment?
Well, I might introduce the organisation. So Thorne Harbour Health started as Victorian AIDS Action Committee in 1983. We were an activist collective that came about in relation to government response in what was seen of the AIDS crisis, which was coming out of the US. There's been a similar response in every state. So we work in Victoria and we co-branded Thorne Harbour Health a couple of years ago. We also work in South Australia, but there is an AIDS council in every state and territory. And then over the last few years, we've moved to LGBT health. So we've moved from disease to cohort, recognising that a lot of the drivers of disease are broader health concerns for LGBTI people, lesbian, gay, bisexual and trans people. And I guess we see ourselves as a community-controlled health organisation. So we're accountable to our communities. We have a community-elected board, and we only provide services to our communities. We don't seek to be any broader than that. And I guess looking at partnership, you know, our cause is very well documented. You know, you can Google the HIV movement. It was very similar in Australia and America and Europe. and very early on, it became about a partnership between community organisations like mine and government and clinical and researchers. There's been a lot of benefit to that. And particularly, we talk about key affected populations. So if you look internationally, the populations affected by HIV are gay and bisexual men, injecting drug users, sex workers, women, particularly in Africa, and people from minority ethnic communities, particularly in European countries and America. But I guess key affected populations, if you're talking about gay and bisexual men essentially and LGBTI communities, we are across all members of that partnership. So we also exist in government and clinical and in research. So politically, we were incredibly successful. Early on, rolling out needle exchange was probably the most important thing that any government did in this country to prevent the spread of HIV. And we were very early in doing that. There's, the United States still hasn't taken that step and is still suffering because of that. So it has been very successful, but sometimes the partnership can be taken for granted. And where it doesn't work, the communities can get very, very close to each other and very supportive of each other. And particularly recently, the last couple of years, as some interventions like molecular epidemiology have come to the forefront. We have researchers very, very keen to roll these out in Australia. Molecular epidemiology is where you track virus through people. And you could use the variations and the mutations in the virus to have a rough idea of who it travelled through and how it got to where it's gotten. It can't prove that person A gave it to person B, but it can roughly say that these were all in a similar cohort. And it is being used overseas, particularly in the United States, to prosecute people. So one such area, in Australia, the researchers are very keen to trial this new technology and roll it out. And the groups are incredibly nervous about how this could be misused within the community, particularly people living with HIV who could be criminalised. So that is an area where things have become tense between the community groups and the researchers and the governments who would like to see this rolled out because it could be a game changer in the management of the disease. But yes, it requires constant work, and I think you need to not take the other parts of the partnership for granted. And I'll leave that one there.
Yeah, that's a great takeaway, actually, not to take those things for granted, because we do have to always work on the importance of the relationship and keeping it valid and relevant to everyone. Ken, could I ask you just to bring your experience with the primary healthcare nurses to look at how networks like the National Patient Organisation Network can engage and collaborate with other networks around Australia to ensure equity for all people living with health conditions?
Yeah, sure. Thanks, Claire. And so APNA is probably got the longest name of all the organisations you'll see on the panel, which is the Australian Primary Healthcare Nurses Association. For those who aren't familiar with primary healthcare, we define that quite liberally, saying if you're not working in a hospital environment, we grab you. And so the great thing about that is that encompasses almost every single area where prevention takes place. And so nurses are the largest workforce in primary healthcare in Australia, and it covers clinical settings such as aged care, general practice, community health, home visiting nurses, correctional care nurses, school nurses. There's a really long tail of them. And I guess the key thing to remember is that by definition, virtually every single nurse working in those settings is in primary healthcare, but they are generalists most of the time. And that means that they've got a really broad remit. And I think that brings me to the question, Claire, which is actually, if you're going to engage with organisations like mine, it's probably worthwhile noting that a lot of the engagement we have at the moment is very transactional. And so what I'd say to everyone listening is it's worthwhile taking the time, and resources are always scarce, right? But it's always taking the time to get to understand more about the organisation and its area of expertise. And so I'd say the number one request I get from organisations that have a health issue or a patient issue that they really want to advance, and we all want to advance them, right, is one, we get it that it's really important, and we get it that's really important to you. But actually, you might be missing an opportunity to really engage with where our agendas are for the primary healthcare nursing workforce. So I'll make an example about that. I would say the number one thing I'm asked for, usually for free, is can you work with us to create a half-hour online learning course on the issue X that you can actually then get your members to do? So I'd say there's several issues with that. One is, why will that be the thing that helps your cause? Because I've got 19 channels in my organization. One of them is online learning. There might be a whole heap of more effective ways that I can get your issue to carve out a few percentage points of my members' brain space, because they're generalists, right? So they're thinking of hundreds of health issues, and they're looking for them when they're doing health assessments or helping patients or consumers to really look at their health issues. So the way you want to carve out time in the mind of someone who's a generalist could actually take many forms, but I'm generally approached in a very transactional way to say, we already think we know what we need, and we need this. Now, in defense, often that's because government has finally given you a grant to say, hey, this is what we want you to do. So your hands have been kind of tied. But the expertise we have is we know nurses. So actually starting the conversation with, hey, we're trying to achieve this, rather than actually saying we want this tactical solution, which is X, actually could lead to a much better conversation. A really good example of that would be, we're working with Family Planning New South Wales, and Family Planning New South Wales wanted to talk about how they could get nurses on the MBS to actually do long-acting contraceptive insertions, so LARC insertions. Really good topic, will make a marked difference to the people that they're trying to get LARC, get using LARC more frequently. And using the largest health workforce in primary healthcare, great way to do it. The issue was that they didn't understand what our position would be on, we agreed with the LARC stuff, but they were actually essentially going to government to say, hey, nurses can do it and you can pay them $15 to do it. Now, to put that in context, a doctor might get paid $80 to do it. So we agree with what you're trying to achieve. We don't agree that a nurse's time should be devalued, because we're trying to get to a nurse's time more valued. So we wanted to support, but we weren't going to support at $15. But there was this assumption being made about how a nurse's time could be valued. And if I'm honest, at the time that they came to us, Family Planning New South Wales was, they were really passionate about getting it there, but they didn't realize that their method was going to undermine what we've been working on as an organization. Now, what we've actually got now is a joint approach, because we've now agreed what the appropriate rate would be for a nurse to do that, so they're not devalued professionally. And actually, you couldn't find a bigger supporter of how we try to advance that. And when you think about it, when we started working together with them, rather than debating the issues, we actually were more effective in doing that. So we've actually got a lot more ears listening to us in government and eyes on what we're trying to achieve there together. So I'd say certainly don't go for that transactional approach. Seek to understand first. There may be a better way of achieving what you're trying to do. And most people say they're trying to achieve awareness. I'm an ex-marketer, so I say awareness is kind of a really, it's a term that doesn't define much, because you're probably not going to have the resources to actually measure that awareness. You're going to say, we did something and we hope it had an outcome. And if you're trying to raise awareness, I wouldn't say do an online learning course, for example. I'd say, why don't we get an interview with a really compelling speaker from your organization on our podcast? Because that's the #1 nursing podcast in the country. I can get you in front of more people than an online learning course ever will. But if we're going to look at how we educate nurses, then actually let's look at how you do that really well, because we've got a lot of expertise in nurses there that we can bring to your thinking. And let's work out how what you're trying to achieve can be best matched with our expertise to really achieve the ultimate goal that you've got.
That's fantastic. And I think now we all want to come and approach you and see what we can do with your nurses.
Well, another thing on that, right? There are things that it's worthwhile asking, because I'd always say, start with those questions about, hey, like if you don't know where your issue fits into a nurse's day in primary healthcare, ask us, rather than going, hey, we want to do this. By the way, like, do you include aged care in your remit? It's that kind of thing where it's funny, the conversations we have sometimes, because we are certainly open to looking at how we can work together. And notice I don't use the term help, because I don't think it's about helping. There's the issue is more about how do we achieve common goals? And if they're common goals, you're not helping us, we're not helping you, we're working together. And that's surely where we all want to be. The other thing is, If your issue is particularly niche, if it's never going to get to the top of a generalist nurse's mind, then actually it's good for you to find that out, because there might be a number of reasons why that happens. It could be that there's no MBS item number for a nurse to bill, so therefore no GP who owns a practice is going to actually earn any money. Actually, so the issue there isn't so much why aren't nurses doing more on that issue. The issue is what's structurally stopping them from doing more on that issue. And let's work on that, right? Because what I can guarantee is that when I've got a workforce survey that tells me that 50% of primary healthcare nurses have been saying for 8 years that they're not used to their full scope of practice, well, let's you and I talk about how we can use your issue to get them working in full scope of practice. Because I know that if I go to government's going to go, oh, that's just nurses trying to get more money. We've been told that as bluntly as you like. But if we are actually saying, you know what, if you open up this for nurses here, then they can do more over here for this specific health issue. And you can work with us to actually be making that case powerfully.
Fantastic. We've got 6 minutes left for this session. I'm going to ask each of you to consider and give me a quick answer on describing how you think the health system would or would not function if health charities or networks did not exist. Paul, we'll just switch back to you.
Well, obviously, I'm no expert on health issues, but I mean, what we see from a refugee policy perspective, is that people who are directly affected by the issues and those who are working day to day on issues see things that government decision makers never see. Another thing we also see in working with government, and I've been working with the Refugee Council for 16 years now, so I've seen a lot of ministers, a lot of policymakers within government come and go, I think the community sector plays a really important role in actually being corporate memory on key issues as well. I'd see, our movements as being, critically important information sources for government policy if we're doing our job well, and also reminding people, the issue you're facing now is actually something that was, we actually saw in 2007, and we can actually give you information from your own department from 2007 about how these issues were addressed. So I think there's a really important role for the community sector to play there.
Fantastic. Simon?
I guess in our case, if we look at something like HIV, you're looking at prevention, and we know how to speak to our communities. We know how to find our communities. We're a reasonably cheap option to do that through. And, we often get overlooked because either they don't count us, they don't ask the right questions, and they don't know we exist. Or, particularly when you're talking about things like sexual health, politicians and bureaucrats are incredibly uncomfortable discussing those topics publicly. They don't know how to deliver appropriate messaging or messaging that people want to hear. And when you're talking about things like trans health, which we're also very involved in, that's a morally, salacious topic that mainstream media love running stories about. And, as we're seeing right now from the Prime Minister, one bill got killed, but he wants to keep certain parts of the community happy. So he immediately launches into a trans women in sport bill. So, we are functioning in a difficult area of trying to push healthcare forward for a population that government are incredibly uncomfortable and don't know how to communicate with. It really wouldn't work for us. Without our organisations existing, we would be completely forgotten about, and we wouldn't be noticed because they don't tend to ask if we exist in the first place.
Which actually brings forward, we had a question pop up in the Q&A, which is, do Simon and Paul work together on strategies to fight stigma? So that actually really loops in with what you're saying there, Simon, is that continuing to battle the stigma, I guess, is a really important role of your organisation and the networks. Fighting stigma is a huge amount of what we do. We run specific stigma campaigns, and we do a bit in the asylum seeker and refugee space, and have just recently in the last few weeks touched on that topic. There are specific LGBTI asylum seeker groups. The Forcibly Displaced Persons Network is one of them. Bridge Meals is another one, and we work quite closely with them and try and tackle that. Stigma is very layered. It's like an onion.
So you add on any other sort of marginality like cultural and linguistic diversity or Aboriginality or disability, and stigma gets much more entrenched and difficult to manage. So yes, we tend to do that across networks.
Great. And Ken, just in closing.
Yeah, so I'd say that every organisation that is trying to advance a cause has a responsibility to set the tone. And that means really pointing, especially out to government, what the next mountain is that needs to be climbed in your area. Because it's very easy to go, oh, you got something last election, or you got something, we changed that policy 10 years ago. And there's kind of this rinse and repeat cycle that is just, oh, well, you're getting that again, so we'll renew the funding. You should be grateful for that, right? But that's not advancing. That's maintaining at that point. So I'd say that, you know, the key things for your disease or therapy or patient focus area is really to reduce that rinse and repeat cycle that government loves to get into, because they love to say that this is you've already got something. So it's reminding people constantly and being that squeaky wheel about what advances have been made. And I really resonate with what Paul said about, you know, reminding government departments about what they decided a while ago and what they decided, but then it got left on the cutting room floor of the last budget or whatever it is, because they have very short memory spans. But it really is setting the tone, because government fundamentally sees all of the issues that you're working on as something that they don't get a return on. And so it's reminding them that there is a return that comes to them, and they measure it differently depending on departments and depending on ministers' personal preferences. But it's worthwhile remembering them, where are we going to with this? Because what they decided 10 years ago was probably an incremental step. So what's the next step they need to take, and reminding them of the next bit. And that's fundamental, because as Simon's just said, the more marginal you get, the harder it is to get them to listen. And so that's your job, to actually make them listen, to be the squeaky wheel, and to let them know what the next stage is for development in your area of specialty.
Great advice. Thank you very much, panelists. That's been a really incredibly informative session in a very short space of time. And I thank you all for your great input and great insights. And it really does show the value of collaboration, and across different topic areas too, that perhaps we need to be a little more mindful of thinking more broadly who we can work with to get our results, the right result. Thank you again. We now have a half-hour break, so come for break, morning tea, snack, 11s, and everybody be back online for 11:30. Thank you.